Hello, everybody. It is intro to cardiovascular system time. I am Dr. Faulkner, and I work in the emergency department at UTMB, all the UTMBs. I know that we haven't gotten a chance to meet in person, but unfortunately, with COVID out there, our shift schedules are not very easy to work with. So you'll pardon me, this is my very first intro pre-recorded. And I do have two dogs who might be running around a little bit, so please forgive me if they walk by. Let's get started. So these are my objectives. You can read them if you want. I wrote them. This is what I want you to get out of my lecture. And because this is the first time that we're meeting, I wanted to include a little extra piece, and that is my recommendations on how to study better. You know, if you're doing some studying and you want to be an efficient studier, you have to learn that studying the first time is going to take more work if you want to spend less time studying. So that means efficient studying is harder and takes longer, but it's definitely well worth it in the long run. That means that what you have to do is find out how to make your learning active. So sitting here in front of the TV screen, listening to me talk, that's not active learning. Even if you printed out my slides and highlighted them, that's not going to be active learning either. What you have to do is you have to find a way to make your learning active. You have to reorganize the information in a way that you understand it. Maybe it means you summarize each lecture after it's done. Maybe it means you make some flashcards or your own chart for all of cardiology. Maybe it means that you take notes on a blank piece of paper, summarizing everybody's general thoughts. Or maybe it means that you teach somebody else. The important part is you need to know the normal, and then you need to be able to guess where that normal can go wrong, and that's going to be the disease. I highly recommend that you go over the information at least 2 different ways. And that doesn't mean like read it and then say it out loud. It means see it in 2 different contexts. So whether it be me saying it to you, whether it be you listening to it on a podcast or watching a YouTube video, or maybe reading it in a book and then also drawing it on a board, whatever it takes, you need to see the information and hear about it twice by 2 different ways. And that is my recommendations on studying better. I also have to give you a little disclaimer here. I have a medical podcast. I started this last year specifically because I teach you guys. And a lot of things that I want to teach are things that are not necessarily covered in your curriculum. And that's because it's very test-based. So I made med mechanics specifically for your class and your students, so that way we can study not just what's on the test, but also what you need to know to stand in front of a patient. If you're interested, check it out. You see I have a website there, and I also have a whole lot of free episodes on all the different sites like iHeartRadio and Spotify and Apple and all those kinds of things. Plus it's free and I update it monthly. All right, so let's talk about what we're going to talk about today. First, we're going to be evaluating patients' cardiovascular status. So that means that we're going to go over skin, things like wet and dry and pallor and color. We're going to be talking about the heart sounds and what you're listening for. And then we're also going to talk about cap refill and leg swelling. We can't get anywhere without talking about cardiovascular status. If we can't talk about vital signs, there are 2 specifically we need to go over: blood pressure and heart rate. Then we're going to talk a little bit about imaging and how we use that to evaluate their status. And finally, we're going to talk about some labs. Then we have to go into a broad overview of cardiovascular diseases and how we evaluate each of those cardiovascular diseases. There are only 3 big ones I'm going to talk about, and I'm also going to mention my way to organize all of the cardiovascular diseases. And lastly, I want to finish up with some cardiac diet information. Now, before we go ahead and get into this, just a good fair warning for this. This is a broad overview. Because it's a broad overview, I don't really know what you've already covered in your other classes and what you haven't. I'm assuming that you've had anatomy before, but I don't know what you covered. So what I did here is I've listed out some review slides. These are things that I have expected you to already know before coming to this lecture. If you don't know these things, then you probably need to stop, pause, and write them down so that way you can review them before you get more into this lecture. So the first thing that we're quick reviewing is the basic anatomy of the heart. Okay, here's a picture of it. It's all beautifully labeled for you. And we also have a picture of the coronary vessels. There's only 3, and you should know them and be able to label them. You should know all 4 chambers of the heart, all 4 valves of the heart, and all 3 coronaries of the heart. I also wanted to let you know that the major function of the heart is to pump. Hopefully you know that by now. And the average size of a heart equals 2 fists put together. That's about the size of your heart. The average weight of a heart is about 7 pounds, which is a fantastic, very underrated Will Smith movie, in case you're interested. Now, the heart and the cardiovascular system, the heart's not all it is. It's also the vascular, right? So it's also all of the veins and all of the arteries. And in case you don't know this by now, the difference between a vein and an artery goes a little bit deeper than which color you color it on the chart, right? It's not even about which direction it goes. It's also an anatomical difference. So we know that arteries are more muscular and they can tolerate more pressure than a vein can. We also know that veins are thinner, but they also have one-way valves to prevent the backflow of blood. We also know that they meet in the middle with a capillary, and capillaries are so small that they only let one red blood cell through at a time. And this is important because this is where all of the exchange of oxygen, nutrients, and waste products happens. Now that you understand those basics, arteries and veins, you also know that typically people talk about arteries going away from the heart, A going away, and veins go towards the heart. And while that is true in general, there's one big exception to that. And that's what I want to make sure you guys know in this review. And that is, of course, the pulmonary vessels, right? The pulmonary veins actually go away from the heart, and the pulmonary arteries go towards the heart. And so you need to know whether they carry oxygenated or deoxygenated blood. And sometimes that gets very confusing. So I want you to have gone through that in your head a couple of times before we move on. Something that will also potentially help you for the future of all of cardiovascular is knowing the path of a red blood cell. Now, I'm not going to go through all of this, and I know it looks terribly complicated, but if you could take a red blood cell and put it in a vein or put it in the right atrium and trace its path all the way around the body, then you're going to be good to go for understanding all of the rest of the disease processes and how to fix them. If you don't know that, or you're struggling with knowing where to start, this is where I would start. I would pick a random area, maybe with your friends, your study group, or your parents over Christmas, who wouldn't love that, and be able to write out all of the path of the red blood cell as it goes through the body. I've added a picture on the side here that show you the path of the red blood cell through all of the different organ systems as well. So the next big review that I want to talk about is a few fundamentals. And I apologize if some of this stuff seems too easy, but it's really important that you have a good base. So the first fundamental is that a heart gets squeezed in the pumping phase. I think you know that. But the heart is a closed loop system. And that means that the heart is never empty. This is a very important concept. Even though it's squeezing out a bunch of the blood, it is never empty. If the blood isn't there, or if the heart is empty, that's going to equal death. This is how air kills us on soap operas when somebody comes into the hospital room and puts a whole bunch of air into the IV line, right? The person always dies. Now, one little air bubble in your IV line isn't going to kill you, but if you have enough air to displace all of the blood and leave the heart empty, aka all it is air, not blood, the heart suddenly can't pump. It requires a little bit of blood left in the heart to be able to pump. So it's a really important concept that when we talk about the heart pumping, It never is 100% empty. This is reflected in a couple of different terms that I have up here for you. The first is the end diastolic volume and the end systolic volume. And that's all about how much blood is in the heart either before or after the squeeze. We also talk about that with ejection fraction, which we're going to get into later in this lecture. But I want you to know that the ejection fraction, which is the percentage of how much blood pumps out of the heart, is never 100% because it never pumps all of the blood out of the heart. I think I have beat this dead horse with a stick enough, but normal is about 55% typically. So we still have a good amount of blood left in that heart. The next big fundamental I want you to know is that the coronary arteries are essentially the Achilles heel of the heart, or kryptonite, if you will. They are the weakest link of the heart. Because the heart is kind of a good drug dealer and it doesn't dip into its own stash, right? The only way that the muscles that continuously beat and spread the blood all over the body get any nutrition at all, the only way is through those coronary vessels. So if we were to block one of those vessels, the blood and the muscle that the blood needs, I said that backwards, the oxygen that the muscle needs, it can't dip into its own stash. So even though it's all in the ventricle, it can't just absorb all of the oxygen from the blood in the ventricle. It has to go through the blood vessels. So some of them, because of the anatomy, get clogged more often than the others. So that means that the left coronary artery, or the left anterior descending artery, LAD, also known as the widowmaker, is the most commonly clogged artery. And then the second most is the right, and then the last one is the left circumflex. It's probably worth it for you to know that order. This is another slide that looks big, bad, and scary, but it's supposed to be for a review. I'm assuming that you have heard all of these terms and definitions and that you know all of these mathematical concepts, okay? I'm just putting them here for you because I'm letting you know that these are things that you should already know. I'm sure that Dr. Beach, if he hasn't talked to you about them, is going to. So it's worth your while to make sure that you go through all of these and understand how they work together. In case you've never seen this before, and I hope you have, I've put this box all together here so you can understand what each thing goes into and how they work together. Okay. So now let's talk about the actual physical exam findings of the cardiovascular system. Okay. So the first is where to listen for the heartbeat. I'm assuming that you've already gone over that, so I'm not going to spend a whole lot of time. I'm also assuming that when you listen to a heartbeat, you know that there's two sounds. We call it S1 and S2, and that it's a lub-dub sound. I'm also assuming that you understand that everything on this slide is the cardiac cycle, and that the cardiac cycle is in two different areas, the systolic and the diastolic. And that the sounds that we're actually hearing when we're listening to somebody's chest is actually the closing of valves very close together. And so which valves are closing are all listed on this sheet. And I'm sure that Dr. Beach is going to go over the cardiac cycle with you. Now that you know what we're actually listening to on the chest, it may not surprise you to know that murmurs are simply extra heart sounds. And like the original heart sounds themselves, almost all extra heart sounds are also caused by valves or some kind of valve problem. Now, before you panic and study a whole bunch of this is just a general broad overview. So you don't need to specifically study all of these murmurs just for me or for this particular lecture. But I want you to know what a murmur is and that there's a whole bunch of them. What you might also notice when you listen to somebody's chest is that some sounds are quieter than others. We call these distant heart sounds or muffled heart sounds. At least that's what you put on your chart. And they simply mean that something is between you and the heart. Now, there's a couple of different somethings, but it could be that this patient is particularly fat. So because they're obese and the fat is in between you and the heart, it's harder to hear. It could be fluid or it could be air. And I've listed here a couple of different examples of each. So there's lots of different reasons why somebody can have distant or muffled heart sounds, but it's something that you should be aware of and prepared for. I also want to talk to you about the skin and something called capillary refill. Again, I don't know if you've heard of this before, but in case you haven't, if you go to the furthest bit of somebody's body, usually fingers and toes, you can squeeze it real hard and you can watch it blanch or turn white. And then you take your pressure off of it and see how long does it take to recolorize. That is your cap refill. Normal should be under 2 seconds. If it's longer than that, then we consider that to be poor perfusion. And we start worrying about things like vascular compromise and particularly shock, which also means poor perfusion. I have another lecture a little bit later on about sepsis and shock, so I'm not going to go too deep into that. What I do want to show you is some pictures of cyanosis. Cyanosis is also a sign or symptom of shock, but it's usually a prolonged lack of oxygen. So it's not a perfusion issue, it's an oxygenation issue. Now remember, sometimes this can be the heart and sometimes this can be the lungs. But what I want you to know is that usually cyanosis is described as a blue color. However, many patients aren't white. You guys, we just got to admit it, okay? So race matters sometimes when we're talking about physical exam findings. And therefore, what I did is I put up a whole bunch of pictures of different age groups for you to see what cyanosis looks like in different parts of the body with darker skin. Notice that rather than being blue, it's almost like a purple or a really, really deep red color. And it's really important that you notice that cyanosis is going to be the most obvious in the clearest cells. And by that, I'm talking about under the fingertips. I'm talking about in the lips. I'm talking about on the tongue and sometimes in the toes. Cyanosis is always serious. It's always a bad thing. And it's worth taking somebody's fingernail polish or lipstick off to look for. I'm also going to let you know that cyanosis is only an early to mid finding of hypoxia or problems with oxygenation. If you have long-term problems with oxygenation, there's a different exam finding. It's called clubbing. And I have a picture for clubbing of you up there. It's these fingernails over here. And that's always an indication of chronic hypoxia. And typically we don't talk a whole lot about that until we get to talking about COPD and other such problems. Now we got to talk a little bit about edema. So edema is another finding that something has gone wrong with the heart. So the heart is functionally kind of two sides, the right heart and the left heart. And there's this picture for you here to kind of help you illustrate this concept, even though that's not really what it looks like anatomically. If the right heart fails and there's a whole bunch of fluid that backs up, what we're going to get is a whole bunch of backup into the legs. And that's where we get pitting edema from right heart failure. However, left heart failure is going to back up in the lungs. And that's when we get shortness of breath and pulmonary edema, which again, we're going to talk about here a little later. But this does bring up the concept of connections. Blood vessels connect the whole body. That's how we get oxygen everywhere. And I do mean everywhere. So when there's a cardiovascular problem that's happening, this is going to affect the entire body. So when you're learning about heart failure or you're learning about coronary artery disease, remember that it's not just affecting the heart and it's not just affecting the blood vessels. It's also affecting your intestines. It's affecting your brain and your kidneys and your liver and the very smallest cells and the very smallest part of you. We don't talk a lot about these, so I want to make sure that somebody has said it. I also want to make sure that you know that there are two particular organ systems that the heart is most closely related to. And the first one is going to be your lungs. And that's because the lungs don't really talk to a whole lot of other organs. It's pretty much antisocial with everything else except for your heart. So if there's a heart problem, the lungs are going to have a problem too. Also is the kidneys. The blood pressure and the kidneys together regulate your blood pressure, and we're going to talk a lot about that later, but you got to know that the heart and the kidneys are very intertwined. So if you have kidney failure, you very often will have heart failure. And if you have heart failure, very often you will have kidney failure eventually. So I want you to understand the relationship of these and just let you know. All right, the next part of this is we've kind of gone through all these physical exam findings. So now I want to cover the vital signs. And it probably goes without saying, but vital signs are vital, right? So 2 of the 5 vital signs that we have are like exclusively heart related, and that's blood pressure and heart rate. Now we got to talk about how you need to make it a habit of, if you go into a clinical room, even if it's just a sim case, even if it's just a practice case, always take a look at the vitals, either on the piece of paper or at the monitor in the room. That's going to make you shine a lot better than a lot of other medical students or any students of any kind. Because if you understand what the vital signs are and what they mean, that's going to tell you how sick the patient is and what kinds of questions to ask. It's also important that you know that blood pressure and heart rate are variable. Yes, I realize this seems pretty obvious, but believe it or not, this is probably the most common complaint I get from patients. They don't understand that the heart simply responds to tissue demands for flow, right? So if you are running a marathon and your leg muscles need more oxygenation, your heart must respond to that by pumping faster and harder to get more oxygenation to the legs. And we care a little bit less about the arms and the intestines than we do about the legs at that time. So if you understand that the heart is always going to respond to tissue demands of what's happening, then you'll understand what changes. So for example, we always talk about orthostatic vital signs in clinic. And typically that means we take a blood pressure and a heart rate sitting, laying, standing. And what's changing there is gravity. And what you don't know or don't think about is that the blood pressure and the heart rate have to change with different gravitational pulls depending on how you're sitting, laying, or standing. Therefore, if we do orthostatic vital signs, and let's say we don't have enough blood volume because we're dehydrated, our body is going to have to work a lot harder to change our blood pressure and our heart rate from different positions. And that's how orthostatic vital signs matter. Now, I've listed here a couple other ways that we change that cause blood pressure and heart rate changes. Notice that physical activity is a pretty significant one, but so is metabolic tissue demands. And this is another one that a lot of people don't connect, even when I sit next to them in the emergency department. And that is, your blood pressure could be high and so could your heart rate because you simply have a fever. It doesn't mean that I have to give you blood pressure medicines. I don't need to lower that blood pressure. What I need to lower is the fever. I need to give Tylenol or ibuprofen, go back and check the blood pressure and heart rate, which have now even become normal because the tissue demand has become normal. So anytime somebody isn't sick or in pain or has a whole bunch of weight gain or weight loss, the blood pressure and the heart rate are going to change. Okay, this will come back later, but if you want to treat somebody's high blood pressure, you can always talk to them about their weight gain or weight loss. Now, this is another fun factor that goes along with our variability. If you want to know how healthy your heart is, it's not about the numbers. I know I need to say that one more time. A lot of patients get that very confused, but it's not about the numbers. It's not what your blood pressure is or how high or low your resting heart rate is. What it is about how quickly your heart can respond to the tissue demands changing. This is why when we typically measure our resting heart rate, and then they'll have you do a whole bunch of physical activity, and then they have you sit back down and remeasure your resting heart rate and see how long it takes you for your heart rate to go back down to normal, how quickly your heart can go back down to normal, how quickly it responds and changes to those tissue demands. That is how healthy your heart is. Another big factor for how healthy your heart is how efficiently it beats. If it takes less beats to meet the same demands, AKA having a lower resting heart rate, then your heart is doing better. Your heart is healthier. The best way to train your heart to do this, besides youth, is to practice. To do something like cardio training, weightlifting, or even high intensity interval training teaches your heart to practice the changes in the blood pressure and the heart rate. And this is how cardio makes our heart healthy. Now, let's talk about what heart rate really is. So, heart rate is simply the number of squeezes that a heart makes per minute. It's that simple. Now, there is a little bit more complexity to what is a normal heart rate, and that depends a whole lot on somebody's cardiovascular status. And a lot of experts argue, is the low rate 50? Is the low rate 60? Nobody really seems to know. So I've put on here that 50 to 100, and you'll probably also see 60 to 90 can be the range. The important part is knowing that that heart rate responds to the body's stimuli, like the exercise and the temperature, the dehydration and the stressors and the pain and the electrolytes, and I think you get it, okay? Remember that it's a response to body stimuli. So it's not always the heart's fault if it's too fast or too slow. Sometimes we have to look for the causes of those things. So let's talk about the heart rate going too fast. The heart rate going too fast is called tachycardia, and we really worry about it, as in it's really red, blinking terribleness if it's 250 to 300. And the problem with the heart rate going too fast is that there's a filling problem. So if it beats too quickly, there's not enough time for the blood to eject and fill at the same time. So because of that, if it beats around 250 to 300 and eventually we don't have time to fill, that's when our heart becomes empty, like we were talking about in the beginning. And that's why it's so important to know that not only is that going to cause major issues, but that can be life-threatening. So we fix tachycardia with medications like beta blockers, calcium channel blockers, and even electrical shock like we see on TV. Now let's talk about the heart rate being too slow, also known as bradycardia. We start really seeing red flags with 20 to 30. Now it doesn't mean that we ignore a 40 heart rate. A 40 heart rate is still really concerning. But at 20 to 30, we need to do something, and we need to do something now. And the problem with a too slow heart rate is that there's a delivery issue. The oxygen is not getting to the brain and to the other organs like it should, and we're going to start having ischemic problems. That's going to be fixed by medications like epinephrine, right? That's going to increase our heart rate, atropine, and also by a pacemaker that's been implanted. Now, both of these problems, either a filling problem or a delivery problem, cause the brain not to get enough oxygen, either because it's not filling or because it's not delivering. And that's going to lead us to syncope, which is the fancy medical term for passing out. Okay, this is one of the biggest causes of syncope, and it's something that you should know. I've also included a really fun fact, something that is a little bit more of an advanced concept, but it's listed up here. It's known as the Fouget sign. It's very fancy, you know, very, very French. But essentially, if your fever is present and your metabolic demands are high, and yet you still have bradycardia, there's really only two possibilities. Either you're on beta blockers and your heart physically can't go higher because the beta is being blocked, or you have the Fouget sign, and that is usually caused by one of these 5 disorders. All of them are infectious and all of them are really rare, but it is a fun fact to know. Now, when the heart rate goes too low, typically we implant a intracardiac device. or an AICD for short. This is just a small, brief introduction to AICDs, and I thought I would give you some fun facts about them. So all AICDs are implanted into a pocket in the chest, and that pocket includes the battery and the capacitor. Okay, there's only 3 brands or 3 manufacturers of AICD devices: Medtronic, St. Jude, and Boston Scientific. Most patients will get a little card with all the information on it, but they should know which brand theirs is because there's only 3 to remember. There's also only 3 types of AICDs. You can either have a pacemaker, you can have a defibrillator, or you can have both. That's all you can have. All of these have the batteries, and you can see them in that X-ray above. The batteries only last about 5 to 10 years. If they're a little older, they only last 5 years. If they're a little newer, they last about 10 years. That means that everybody needs a battery replacement. And that also means that the battery could run out of your pacemaker. Always room for problems. I also want to make sure you know that MRIs are a giant magnet, and magnets and batteries usually don't get along. However, because we are a very advanced culture, a lot of these new AICDs that are placed, usually at least within the last 5 years, but sometimes even longer than that, are safe for MRIs. So that's something that you should know. When was this implanted? Should be a question for your patient if they have a pacemaker and they need an MRI. Now, I want to talk to you about how to differentiate whether they have a defibrillator or a pacemaker on chest X-ray. So I've listed here some reasons why they would have one or the other implanted. But what I really want you to see here is that if they have a defibrillator, which is the word for external defibrillators, are the wonderful little shock pads that everybody talks about in medical shows, you know, charging the machine and then saying clear and slamming that shock down on that patient, right? A defibrillator is simply an implanted inside shock. And what we're looking for is that you need 2 paddles. So you typically need 2 coils. Now, these coils are seen on chest X-ray, and that's how we know it's a defibrillator and not a pacemaker. So the coils are these thickened pieces that these arrows ever so kindly point towards. Excuse me. Ugh, too much talking. Sorry about that. All right, so a pacemaker is going to elicit little tiny electrical shocks into the heart because for some reason the heart is going too slow. So what we're looking for, if it's a pacemaker, is at the very, very tip of the lead, what you're seeing is a very thin little line, almost like a stripped wire. And that's pretty much what it is. It's a stripped wire to be able to shock whatever cardiac muscle is right beneath it. So the wire is coated, so we only shock one little area of the heart. So then the rest of the electrical activity can go throughout the heart. So you can see that the difference between the two is the coils versus the end of the lead. So now we need to talk about blood pressure. What is blood pressure? So you see here that everybody teaches 120/80, which is kind of like this weird fraction that we're all just sort of randomly expected to know. 120/80 is the general average heart, like blood pressure that everybody talks about. But what these numbers actually mean is that 120 is your systolic pressure and 80 is your diastolic pressure. And what that equals to is the minimum and the maximum pressures. So if we were able to cut off your arm, because that would make total sense, and put a cuff on there, what we would do is we would be able to see that the max pressure and the minimum pressure is when your heart is beating. So at the maximum, when your heart squeezes, the pressure that your heart can squeeze out, that's the top number. And when your heart's relaxing and when it's not beating, that's the low pressure. So if the low number is high or really high, usually over 100, that means that those blood vessels are never given a rest. And if the top number is low, then that means that the pressure may not be high enough to get blood to all the places that it needs to go. Now, a little clinical vignette down here. For a lot of you who may not know, you can get false blood pressure readings. Now, how does that happen? Most false blood pressure readings come from a cuff, blood pressure cuff, that is either too big or too small. So if you have too big of a blood pressure cuff and it squeezes, it's going to give you a false low blood pressure because it doesn't have to squeeze as much to compress everything. And if the cuff is too small, it's going to give you a higher blood pressure because it has to squeeze more. Okay, so the important part of all of this is if you have a false reading, you may want to check the cuff first to see if that's actually your patient's blood pressure or not. All right, now we got to talk about blood pressure components, what the blood pressure actually is, what it means, what it does, etc. So you see a little bit of a math concept up there. Blood pressure is cardiac output times systemic vascular resistance. What I want you to get out of this is cardiac output, which is kind of like the ejection fraction of your heart, how much blood is actually being pumped out of your heart. That's not something that I'm going to talk about with you today. That's going to be something for Dr. Beach to cover. What I want you to know is that your heart has to beat against the resistance of the rest of your body. So how much pressure it takes to squeeze that blood out of your heart and into your body, that's the resistance. And there's three components of resistance that we care about from our standpoint in clinical. And those three determinants are the blood viscosity, or how thick your blood is, right? And two big determining factors is if you have anemia or if you're dehydrated or overhydrated, that can really change your blood viscosity. Another option is your blood vessel length, right? How long or short that blood vessel is. That's going to determine how hard it is to push that fluid through. So pushing your fluid and your blood down into your toes is a lot harder than it is to push it into your kidneys. And the last determinant of resistance is the radius of the blood vessel. Now, this goes into a lot of math concepts, and if you're really excited about that, I'm sure Dr. Beach would love to talk to you about that every day, all day. But what I want you to know is that this blood vessel radius is all about whether the vessels can constrict or expand. Vasoconstriction and vasodilation is one of the biggest factors in changing your blood pressure. So when we talk in pharmacology about how to treat blood pressure and how to change the output of your heart, we can talk a whole lot about how to constrict or dilate certain parts of certain vessels in certain areas or all over, and that's going to be able to change your blood pressure. Now, I want to take us through an example of this just so you believe me. The biggest and most beautiful vasodilator that we use almost on a daily basis in the emergency department is nitroglycerin. This is a picture of it over here. They're tiny little tablets, and you can actually absorb them through your skin, so you have to place them under the tongue, and boy, do they work quick. What they're actually doing is vasodilating. And they vasodilate your veins a lot more than they vasodilate your arteries. So if you have a whole bunch of chest pain, what happens when I give you some nitroglycerin is all of your veins are going to dilate, which dumps all of the blood, at least temporarily, into your venous system, right? So there's a little bit less blood that's making its way back to the heart, which in turn decreases how hard the heart has to work. So if the heart has a disease or a problem or a clot or whatever the issue is that's causing the chest pain, and I widen out all of your veins, that's going to make less blood go back to the heart. And therefore, it's going to relieve some of that strain or stress or pressure on the heart. Now, this is going to happen so quickly that the most common cause, or the most common side effect, I should say, of nitroglycerin is an intense headache, because boom, it drops that blood pressure. And that means that even though the heart's getting less blood, it also means that the brain is getting less blood. And that typically causes a headache. So, fun facts. Now, there are only 3 ways that blood pressure is regulated in our body. And I'm going to talk about all 3, but only in very, very brief descriptions. The first is going to be in your kidney. There's something called the renin-angiotensin system, which you're going to learn to hate, to be honest. It's very complex. Dr. Beach is going to tell you all about it. But the long and the short of it is your kidney is going to determine how much water you pee out and which vessels are going to constrict or dilate, which you already know is a big deal for determining blood pressure. Now, the 2 other ways that we regulate blood pressure is, one of them is called a baroreceptor. So let's talk about baroreceptors. There are really only 2 locations they are found in the body. The first is right in your carotid arch, right when it comes out the heart. These little X's are the baroreceptors in your aortic arch, and those are going to sense that pressure really quickly. The other ones are located in your carotid sinus, right? Those are located up here in your neck. And this is why if you go into SVT, we can rub your neck real hard, because that will cause your pressure to decrease. So these receptors detect stretching and pressure. And so if the pressure is too high, it's going to tell your kidneys that we need to pee out more water. If your pressure is too low, then what it's going to do is it's going to kick in an autonomic system, and we'll talk about that later, and boom, it's going to tell your body to pass out. If you pass out, what that does is it flattens the plane so your heart doesn't have to work as hard to get blood to your brain. So if your blood pressure is too low and it happens very suddenly, your body knows and it'll make you pass out. That's how syncope works. So now let's talk about your autonomic system. So that's located down here. And your autonomic system is all about your fight or flight and your rest and digest. And that means your sympathetic and parasympathetic. So obviously, if you're running from a lion with the fight or flight, you want your heart rate and your blood pressure to go higher, so that way you can run further and faster away from that lion. In your rest or digest, or your parasympathetics, that's when you need to chill. So your heart rate and your blood pressure are a little bit lower when your parasympathetics are activated. And how that works and all that, we're going to cover in a little bit later lecture. So I'm not going to go too deep into any of those. Just be aware that all 3 exist. Oh, that's fun. Okay. Well, now we get to go into a little bit, before we move on from our vital signs, into a little bit about peds and embryos. And I know that you're pretty excited about this, but in case you have any complaints, this section in particular was requested from 2 second years who worked with me in the department while I was working on this lecture. Those 2 are Andrew and Jensen. They both said they would be happy to accept your hate emails. That said, we want to talk a little bit about embryology in order to be able to talk about pediatrics. So the first thing to know about the heart and embryology is that at 5 weeks, that is when the heart starts beating. That is undisputed, and it is a number that you should probably know. Now we got to talk about this umbilical situation, because one of the big differences between a baby's heart and somebody who is in the womb is, how do we get the blood? So we already know a little bit about the placenta, but what I want you to know is that there is one umbilical vein and there are two umbilical arteries. Now, not always, because it is abnormal, but some people only have one and one. That said, they can be in almost any configuration. And you can see here multiple configurations. This is a real umbilical cord. So what you can see is that there are two arteries that are thicker here, and then there's one big vein right here. So this is the vein, and this thicker one is the artery. And we know that because arteries and veins are different, right? So the hard part about understanding this umbilical situation is that the umbilical vein carries the mom's blood in. So actually the vein carries the higher pressure because the mom's blood pressure is higher than the baby's blood pressure. So the umbilical vein is carrying the oxygenated blood in, and the umbilical arteries are actually carrying mixed blood out. Now, to explain that a little bit more, let's talk about some fetal circulation. Now, again, I don't know if you've had this before or not. Maybe this is a review of all of the different anatomy that you've already had, and maybe it's not. So I'm just going to go through a few highlights of this. So the big thing to get out of the fetal circulation is that there's really three particular structures that you need to know, and their whole goal in the fetal circulation is to bypass things that the fetus doesn't need right now. So the first is that the ductus venosus is going to bypass the liver. So that way when the blood is coming in from the mom, it can just be dumped directly into the heart, and it doesn't have to go through the liver first. So ductus venosus bypasses the liver. Eventually it becomes a ligament. I'm sure you learned specifically what ligament in anatomy class. I don't really care about that right now. The next big bypass in fetal structure is the foramen ovale. You can see that there's a hole in between the right atrium and the left atrium. The whole goal of this is to be able to bypass the lungs. So that way the blood from the mom can be dumped straight over into the left side. Remember that the fetus doesn't need the lungs right now. It's not saying that the lungs don't get blood, because some of the blood still can go up and out and into the lungs, but the lungs can't oxygenate them right now. This closes with pressure, and we're going to talk about this a little later. And then we have our ductus arteriosus, also shown up here, and that's to connect the pulmonary artery to the aorta. So that way, all the blood that comes out through the pulmonary artery also can be dumped straight into the aorta and get into fetal circulation. So this is all to bypass the left ventricle. And this too becomes a ligament. So now we have these three fetal structures, and we know what they become and why they're there. So now I want to take a minute and talk a little bit about the foramen ovale and the closures of the foramen ovale and how that works. All right, I think I got all of that. Almost. All right, so in order to be able to close the foramen ovale, you have to understand that in utero, the baby's heartbeat and the pressures in the heart are way different than they are in, I guess, the adult or the child. The adult in child? I guess in utero and out of utero. Let's say that. Okay, so they're different in utero and out of utero. That's great. So that means that the pressures in the right side are way higher than the pressures on the left side. And that's because mom's blood pressure is higher than the baby's blood pressure, which has a little bitty tiny heart, right? Okay, so now that we understand that the pressures are different, we're going to mix things up a little bit, and we're going to be born and take our very first breath. And that first cry, that first breath that every mom holds their breath for to listen for, what that's going to do suddenly and instantly is it's going to change the resistance in the lungs. it's going to pop open all of the air, and then all of a sudden it's going to flow really, really well through the lungs. When that happens, pressures in the hearts change almost instantly. And instead of the pressure in the right side being way high, all of a sudden the pressure is going to go skyrocket through the left. When that happens, and the left side is more than the right side, boom, that's going to shut and close, man, the foramen ovale. It's going to pop that baby closed. Now from there, that increased oxygenation of the blood is going to go sky high because our lungs are now finally getting oxygen and our foramen ovale are closed, so we're not getting deoxygenated blood into our main system. And that's going to decrease our prostaglandins. Now, don't ask too many questions about that because we're not exactly sure why it happens. We just know that the prostaglandins are going to go down. When the prostaglandins go down, that closes the ductus arteriosus that connects the aorta and the pulmonary vessels. Okay, this is one of the big reasons why we can't give NSAIDs to pregnant moms or to babies under 6 months, because we don't want to close that ductus arteriosus until we don't need it anymore. And if we have a congenital heart baby where we need the ductus arteriosus open for some reason because there's too many things closed or open, then we give them prostaglandins when they're born. This is an important point to remember. But what happens to the foramen ovale? It actually takes 6 months or a year to completely grow together. So that means that normal babies have a little bit of leakage from that foramen ovale, depending on the pressures in their heart and the way they cry. That means that heart murmurs in children under 3 years old can be normal. Now, it doesn't mean all of them are normal, but it means that there is a normal childhood murmur in under 3 years old. There are also murmurs that exist because they have a ventricular septal defect. Again, I didn't get too much into that, but that is one of the most common causes of murmurs in children, and it's one of the most common causes of congenital heart problems, or the most common congenital heart problem. Most of these close on their own by age 3. So parents don't have to freak out about it, and you don't have to freak out about it. Now we finally get into pediatric vitals. I'm not going to lie, I really don't like seeing pediatric patients because their vital signs are all so different, and it's so frustrating. I don't know if you noticed, but when I was talking about heart rates in adults on that slide, I had a particular equation that I have listed right here. And that is, we get a high heart rate if you have a decreased size and an increased metabolism. This is a very fundamental concept that's true in all mammals. And it's not just true for kids, right? Kids are small size, high metabolism, they get a higher heart rate. But it's also true for animals as well, right? A small dog has a high metabolism and a small size, and therefore he has a high heart rate. Whereas an elephant has a low metabolism, but a big size, so they have a really low heart rate. This is an important concept because when we're talking about fetal heart tones, that means the baby is still in utero. Anywhere between 180 to 130 can be normal. That's even true of brand new infants. It can be anywhere between 100 and 160, and that's a hell of a range, you guys. So, because those heart rates change variably, so do our blood pressures, right? The smaller the body and the tinier the squeeze, right? The smaller the cardiac output, the lower the blood pressure. This is why typically we don't take a lot of blood pressures of pediatric patients. When a baby is born, we check their heart rate and we check to make sure they're breathing, but we typically don't take blood pressures, right? Because the blood pressure is going to be like 60/40, which is fine in a baby. Now I have a really weird question for you. If I'm telling you that a child's heart can tolerate a heart rate of 150, why can you at age 20 something not tolerate that heart rate? Remember, that's what I said earlier with the problem with the filling. Any guesses? I know I'm not really there, but I have to ask anyway, right? We have to be involved. So a child's heart can tolerate a heart rate of 150 because it's smaller. And even though it's beating faster, the time in between each beats is smaller, but because the heart is smaller, it has time to fill. Whereas your heart at age 20 is a lot bigger than an infant's heart. And so when it beats at 150 or 160 or 180, it doesn't have time to fill. So the difference, the size difference, really does matter. Okay, let's start talking about labs and imaging. So the first thing we got to talk about is cardiac markers. This is something that comes up all of the time. And I know that cardiac markers are basically released when the heart muscle is damaged. So the muscle is damaged and something from inside the cell is leaking out into the blood that's not supposed to be there. One of the things you're going to notice about all of these different graphs is that they're all showing you how high they go up and how long they're elevated. So that means when heart muscle is damaged, it has long-lasting effects, not just in hours, but also in days. And when we're testing this in the emergency department or in clinic, what we want to know is we don't want to have to see somebody within the first 2 hours of the chest pain. We want it to be able to test it and it to be reliable, even if it's been 2 days. Because of that, we want to get something that is really pertinent as far as the timing, but we also want to get something that is very specific to the heart, right? So what you can look on this chart and see is that we have AST, which is a liver enzyme. So if it's high in liver problems, but it's also high in heart problems, then how do we know where to look? That's probably not a very good cardiac marker. What about something like LDH? LDH can be high in so many things. It can be high in heart damage, but it can be high after a infection. It can be high after you run a marathon. It can be high after you have pneumonia. There's a million different causes. So when we're looking for something that's high, but also specific, the number one cardiac marker that we always land on is troponin. Now, I know this is little bit of some PTSD right here, but troponin, there's actually 3 different kinds of troponins, and they are all located in the muscle when you learned about muscle contraction. So troponin T, I, and C are all there. And troponin is specific for heart if we use troponin I. Troponin I is typically only found in the heart. It's supposed to be inside the muscle. So if it's in the blood, it's not supposed to be there. It elevates in 4 hours and it stays up for a whole 7 days. Now, I know this chart shows you troponin T, but I'm just saying that we've advanced in the world, so we use a lot more specific troponin. But what you can see is that at the 4-hour mark, that's the magic number. And it elevates for about 7 days. So if you have a patient who comes into the ER with chest pain for 2 hours and they have a normal troponin, that doesn't tell you a whole lot. Typically, we want to wait and we do something called a delta trope. Delta is the medical term for change. It's also very commonly abbreviated as a triangle. So when somebody shows you that we're going to do a delta troponin, that means that we're going to do the change of troponin over time. We'll get somebody comes in for chest pain. So when they first come in, we get a troponin level, but it's only been 2 hours. So then we get a troponin level 2 hours later, and we see whether there has been a change in that troponin level. Has it gotten higher, lower, or stayed the same? This is how we determine how critical the chest pain is and what kind of state the heart is in. However, I also want you to notice in this big old purple box right here that there are a million other causes besides heart attack, right? Also called STEMI, of why your troponin would be high. Notice that you can have all kinds of heart infections, or you could have some kind of kidney problem, or you could have a blood clot, Or you could have a couple of different kinds of medications. You could have had a heart shock, right? There is also something called demand ischemia. And this is something I want you guys to be familiar with. Demand ischemia means that something's happening in the body that's requiring the heart to work extra hard. And just like any other process in our body, if the heart has to work harder than it needs to work, eventually it's going to start leaking a little bit of stress enzyme into the blood. And that stress enzyme is going to be the troponins. It's working so hard and so fast that a few of those cells rip and release that troponin by accident. So when would this demand ischemia happen? Well, it might happen when you have sepsis, which is an extreme infection that we're going to talk about, I think, next week. It might happen if you have a total body burn or if you've had some extreme exercise. It can even happen when your heartbeat is beating too fast, right? It's beating too fast and it's working too hard, and so it rips and releases some of that troponin. Now you can imagine that demand ischemia is going to have a troponin that's going to be less than, let's say, a big massive heart attack would be. And demand ischemia is not going to be continually going up and up and up and up. So that's where it's so important for the delta trope to come into play. All right, let's move on from troponin. The next lab is the pro-BNP. So notice that's not BMP, right? The BNP is your basic metabolic profile. BNP stands for brain natriuretic peptide. And I know what you're saying. You're like, dude, why are you talking to me about the brain when we're talking about the heart? And the answer is that the people who first found and discovered this peptide found it in the brain. But when we actually understood what we were doing with ourselves, we found out that it's actually released in the atria of the heart. And it's released in response to atrial stretch or tension. So that means the more blood or fluid we have in that atrium, the more it's stretched and the more BMP gets released. So the higher that BMP, the higher that there's fluid in the atrium. And there's really only two causes that we get too much fluid in that atrium. Either we've got some kind of heart failure or we've got some kind of kidney failure and we can't pee it out, right? There's only those two typically. Now, because this value is just about stretching, just getting one BMP one time randomly is not enough to diagnose you with heart failure. And typically what we do with this is we get a value so that way we compare it to previous, and we get a value so we can trend it over the long term. Okay, this is not like A1C. This is unlike any other lab that you've learned about yet. So you should know that the BMP you can get, but we don't know enough to make a diagnosis off of it. I also want you to know that we're talking about number in the thousands to be impressive. So if your BMP is 250, I laugh and move on. If your BMP is 500, I still laugh and move on. If your BMP is 1,000, I start looking at it and caring about it. So I've put a couple of different ideas so that way you can take a look at it in these charts over here. So these give you a better understanding of the different levels. Again, you're going to learn a whole lot more about this later, so just know about it. Next is chest x-ray. Now, before you guys get excited, I am not teaching you how to read a chest x-ray right now. Most chest x-rays give you a lot of information about the lungs and the bones and the stomach and all that kind of stuff. What I'm talking about is the heart only. So I want to point out just a few things. The first is that you can see the aorta or the aortic notch. You can tell whether it's big or small, which might tell you whether somebody has an aneurysm or not. You can also see the size of the hearts and the shape of the heart. These are also going to be big players when we're talking about assessing somebody's cardiovascular status. So let's talk about how chest x-rays help us understand where the heart is in the chest. Now, I know, don't roll your eyes at me. I know you've already done anatomy, okay? But when we draw the heart in the chest, most people draw it straight on. And what you need to understand is that the heart does not sit in the chest straight on. And it's also, while it points to the left, it's not on the left side. It's in the center. There are lungs around it. The heart is in the middle of the chest, okay? It does have this little tip that points to the left. That's good to know. But it doesn't just tip to the left. It also is rotated sort of posteriorly. This is an important concept. Okay, let me show you with my little drawings over here. We're going to go to this bottom one, the side view first. So you can see that the heart is tilted towards the back just a little. It kind of leans against the spine or the esophagus just a bit. You can also see, based off of these frontal images, that the most posterior chamber is going to be the left atrium. That's what's leaning against that spine, okay? And then we're going to have the right atrium, which is kind of more forward. Then we have the left ventricle, which is pretty posterior. And then we have the right ventricle. So you can see that if I was to put the heart in the chest, rather than putting it straight in, we're going to tilt it backwards and rotate it to the side. This is important. If somebody stabs you in the middle of the chest, you need to know where to look, because what chamber that hole is in is going to matter for this person's life, whether it be minutes or hours. And it's going to depend on where we plug the hole. So please understand where the heart sits in the chest, especially because there are some problems with that. There is something called dextrocardia, which happens when the heart forms. And again, I didn't get very much into that because we don't want to talk too much embryology here. But instead of the heart pointing towards the left, the heart is rotated and actually points towards the right. This is called dextrocardia. But it doesn't really end there, because you could have more than just dextrocardia, which is just simply the heart pointing in the wrong direction. You can have something called situs inversus. Situs inversus means the whole body has flipped. It means that not just the heart is on the wrong side, but the liver and the stomach and everything that is supposed to be on one side or the other is actually on the opposite side. The way to tell this from a chest x-ray isn't just to look at the heart, which we just did here, but it's also to look for the gastric bubbles, right? Your stomach has a little bit of air in it, and air is black on chest x-ray. So we can see those gastric bubbles is actually on the right. This means that this person doesn't just have dextrocardia, they also have situs inversus. All of their organs are on the wrong side. Now, I have diagnosed a couple of people, mostly children, in the emergency department with this who didn't know they had it, because how would you know? This mother was very concerned, and she asked me what this means for her child and whether or not I needed to refer to a cardiologist. And the answer is, I didn't, because this is like a way cooler, rare version of being left-handed. It doesn't change anything for you. Everything still works the way it's supposed to, but instead of listening to the heart in all the usual places, you have to listen to it on the other side. So this is a cool thing to know about, and now we can move on. All right, next thing in chest x-ray that is good to know is the cardiac silhouette. I am going to teach you a little bit about how to measure it. It gets very exciting and super fancy. And by that, I mean it's not very hard and it's not super fancy. What you need to do is you need to measure the entire length of the lungs and or the chest cavity. And then you need to measure the heart at its thickest point. This should be 55% of the total or less. If you need to, you can calculate it doing it by fractions. So let's say this is 8 centimeters, right? and this is 4 centimeters. You can already tell by looking at that, that this is only 50% of the entire chest cavity. Now, obviously your chest cavity is a little bigger than that, but I'm just using easy numbers here, okay? So you get the idea. There are measurement tools in every single system for radiology. Here's another picture of looking at the aortic notch and all of the different outlines of your cardiac silhouette. And finally, I wanted to show you a quick picture. I know this is pointing to the lungs, of not just how big your heart is, but if there's a whole lot of white in the lungs, that could mean that you have some pulmonary edema, which, if you remember, is probably one of the first signs of left-sided heart failure. So that can be related to the heart as well. All right, now we're almost done. Now we're going to get into the big 3 heart diseases. And we're going to talk about the clinical evaluations of them all, just so you understand on the most basic of levels what they are and what we do to try to evaluate how bad those diseases are. Before you get too excited or too overwhelmed, I want you to know that you are probably going to get multiple talks on each of these diseases. So you only need to understand the very basic fundamentals for me, and you need to understand the basic fundamentals for how we evaluate this. Okay. I'm also going to take you through real fast my organization of cardiovascular diseases, because sometimes it can get very mixed up. So I recently bought a house, and I like using the house philosophy for understanding cardiovascular diseases. So that means that there are only 3 components of the heart. Really, you can have structural problems, right? That's the walls of the chambers and the valves and that kind of stuff. Or you could have electrical problems, or you could have plumbing problems. And that's going to be able to help you understand what kind of tests we can evaluate for each kind of problem. And some of the diseases might have multiple factors going into them. Let me show you what I mean. So if we have a structural problem, that means that's the physical anatomy, or the walls and valves of the heart. We evaluate physical problems with things like a chest x-ray, an ultrasound or an echo, or a CT and MRI. That's really the only things that we can do without cutting you open, which is how we fix a problem. If you have a physical wall problem, the only thing that we can do is demo, right? So we can do surgery, we can do transplants. Very rarely we can do medications. And sometimes we can just tell you, well, don't walk there. Now, some of the example diseases of this is things like congenital malformations, and that can be in the walls or the chambers. We also have problems with valves. You can have problems with cardiomyopathies, which you're going to learn about. You can have tears in the walls, or you can have problems with weak links, right? Weak walls, not doing their job. It's still a problem if your upstairs has weak floors, right? Even though there's no real tear, it's still an issue. Now we can talk about electrical problems. So we talk about conduction pathways of the heart and action potentials. And I have great news for you. I'm doing an electrical talk for you a little bit later. So how do we evaluate electrical potential of the heart? We do that with EKGs, looking at your heart rate, and also doing something called a stress test. And we fix electrical problems with more electricity. So we really can only shock or restart your heart. We can do an ablation, which is intentionally burning some of the electrical pathways of the heart, or we can put in a pacer defibrillator device. And how can it go wrong? Electricity always goes wrong in all kinds of weird ways. We can have blocks and shorts. We can have problems with it going too slow or too fast or not doing what we want it to. You know, sometimes you just got to do the on-off trick and just restart it, right? That's kind of what a shock does to the heart. And then finally, we have our plumbing problems, okay? So this is the movement of the blood effectively through the vessels. And this plumbing problem isn't as simple as a house, because you got to remember that the plumbing in us is variable, right? We can have that vasodilation or vasodilation or vasocontraction. And in a house, the pipes don't move, but in a heart and in the cardiovascular system, it does. So we evaluate that with things like blood pressure and cardiac catheterization, which is kind of like roto-rootering your pipes, right? We can also look at things like calcium scores and troponins and our BMP. And we fix this with medicines, but we can also fix it with cardiac catheterization or stenting to reopen the pipes, or we can reroute the pipes even with surgery called cabbages. We'll talk about that later. And it can all go wrong because we can have like clogs, like cholesterol or plaques. We can have blood clots or big clogs again. We can have hypertension, or we can have leaky valves or leaky pipes. It can all go wrong very, very quickly. So now you understand the 3 ways that I like to look at the heart diseases. And if you understand those, you can also understand what tests we need to order and how we can typically fix the problem. So let's talk about some of them. The first and most famous is the ACS spectrum. This is the acute coronary syndrome spectrum. Now, I realize that this is a very janky picture, but I made it myself, so take it or leave it, right? What I want you to know is that this always is the chest pain issue, and that you're going to have some kind of problem with plaque buildup. We often call this coronary artery disease, and there's some kind of issue with plaques building up. That narrows your vessels and causes your pipes not to work well. We can fix this with exercise and diet. Then if it gets worse, it can move on to something called stable angina. Stable angina is chest pain because of the narrowed arteries, but not enough to cause true disease yet, not enough to show up in the blood. Eventually, that can progress to something called unstable angina, which means that you can have pain of the chest due to the narrowed arteries and plaques, even while at rest, even while watching TV, even while the heart isn't demanded upon to do anything. This starts to be where our problems lie. And this is why we check unstable angina and the other problems with something called a stress test. The next stage in this spectrum is something called an NSTEMI, or a non-ST elevation MI. This is a heart attack or a silent heart attack because it doesn't show up on the EKG. An NSTEMI needs to be fixed with a cardiac catheterization. And the way that we detect these, besides a chest pain, isn't the EKG, it's the level of the troponin in the blood. Remember our cardiac markers? And then our last step in this process is a true STEMI, or a true ST elevation MI, a real heart attack. Now, a heart attack happens because there's some kind of blood clot or narrowing of the artery or blockage of our coronary vessels. Remember, it's the Achilles heel of the heart, right? And because it doesn't dip into its own stash, if that vessel is clogged, then that means that the heart muscle starts dying. And that's a big problem for the rest of the body. And you remember that we have 3 coronary arteries, so we can have up to 3 vessels blocked. Now, obviously, that gets very concerning. And if we start getting more than 1 vessel blocked, that's when we start talking about a cabbage, which is a surgical procedure. Again, we're going to talk about that here just shortly. But what I want you to understand is that all of these are on a spectrum. They're all interlinked, and they all ultimately culminate in heart failure. So let's talk about stress tests, cardiac caths, and cabbage. Stress tests. Stress test does what it says. It stresses the heart to try to find the heart having problems when more demands are met, right? If a healthy heart is a heart that responds to the tissue demands for flow, then an unhealthy heart is a heart that can't meet the tissue demands when the demands go high. So what we want to do is we want to create an increase in the tissue demands to see if the heart can meet them. The first and best way to do that is on a treadmill stress test or an exercise stress test. And we hook them up to a monitor and we try to see if we can stress the heart and what happens. If somebody is not in very good shape or they have other medical issues, we can do something called a nuclear stress test, where we push medicines to make the heart elevate and increase its heart rate. And that's how we do the stress test. Obviously, a positive test means that we have a coronary artery problem, and a negative test means that it's probably safe for them to go home. Now, if we have a positive test, or if our ACS spectrum gets worse, that's when we need to do a cardiac cath. So a cardiac cath happens with a cardiologist, and they either go into your femoral vein or they go into your radial vein, and they put a little scope down into your heart to actually visually look at your coronary artery vessels. They release a bunch of dye into your system, and by looking at that dye, they see whether there is a narrowing of your blood vessels. And so you can see a picture of the narrowing here, here, and even here. Now, if the narrowing is more than 70%, that is when they do something about it. If it's less than 70%, they don't think it causes much problems and they don't do anything about it, other than to tell you you need to improve your diet and exercise. Now, that said, if you're more than 70%, what they do, since they're already there and looking at that artery, is they put in something called a stent. And a stent is a mainstay. All it's doing is a little metal piece that pops open the artery. So you can see a picture of what they do here. They put the guide wire in with a little balloon. They blow up the balloon to smash those plaques down. And then they put the stent there to hold it open. This is what a real stent looks like. Now, there's different kinds of stents and different size stents, and we could go really into detail about this. There's a whole specialty related to this, but just know that that's what it is, and that's what we're looking for. Now, if you have a really bad heart disease and a stent isn't enough anymore, or there's more than one vessel that are involved, you can get a coronary artery bypass graft done. This is known as a CABG. This is done in surgery where they actually go into your leg. They take out your great saphenous vein. That's the most superficial and the longest vein in your body. And then they go up into your heart and they hook it up in a variety of different ways. Now, you can have a single artery bypass, double, triple, or a quadruple artery bypass. And the more bypasses you need, the worse off your coronary artery disease was. Now, you can imagine that if they have this bypass, the heart muscle is now able to get the blood and it sort of fixes up some of the problem. But you can also imagine that if you're sick enough to get this surgery, your heart muscle probably already has muscle damage there. So if you get a CABG, all patients, even after the CABG, are going to have some level of heart failure because they were sick enough in the first place to get it. And that's all I'm going to cover for that. Let's move on to the second of the big three, and that is heart failure. Now, this is a lot of information all at once, but know that this could have been way worse. There are lots of different causes of heart failure, and that's what I just circled. But what I want you to know is that there are so many different types of heart failure, and some people talk about and argue about the different types, and I'm not going to really go into that. But you can have right and left heart failure, or you can have both. You could also have diastolic heart failure and systolic heart failure. So think about it, cutting the heart in half, right and left. and then diastolic and systolic, right? Now, the last piece of information on this is all about the classification of your heart failure. The heart failure is, again, a syndrome, not a diagnosis. So it's classified in 4 different stages, and all the stages are clinical. So it's about how much activity you can handle without having symptoms. There are lots of different classification systems. And again, I'm not going to get into that because you'll have a whole lecture on this later. What you need to know is that in order to be able to evaluate our heart failure, besides the BMP and the chest X-ray that we do, we also can do something called a cardiac echo. Now, there are 2 different echoes. There's one that's done through the esophagus and one that's done through the chest. So notice the one that's on the chest is just an ultrasound, put on the chest, and we look at your heart. Okay. The one that's done on your esophagus, you have to be knocked out for, and we put it through your esophagus to get a closer up, better picture of the heart. So what I want you to see here is that the esophageal echo, also known as a TEE, is the preferred cardiac echo. But the one that we do in the ER, in case you're really sick, is going to be the thoracic echo. Okay. So, sorry about that. My GIF stopped. So I wanted you to be able to see some of the movement of the heart and how you can see a much clearer picture through the esophagus than you can through the thoracic chest. And some of that is all about going through the lungs and if people have a lung injury and that kind of stuff. What we do with this echo is we find the ejection fraction. I don't think I said that. So we're looking for how well the heart is beating. We're looking at the structure. We're looking at whether it's dilated or constricted, whether there's any problems with any of the valves. And most importantly, we're looking at that ejection fraction. All right, the last of the big 3, and one of the biggest risk factors for almost all of the cardiovascular diseases and some of the big problems in our culture and society is all about hypertension, which is the silent killer, okay? They call it the silent killer because it can lead to all kinds of problems, and typically people with hypertension don't have any symptoms. So this is a case of us kind of treating the number rather than the patient, but it's in preparatory reason, which is why what we need is 3 separate readings to be able to diagnose somebody with hypertension. Remember that your blood pressure can be high for lots of different reasons, including anxiety or pain or other disease processes. That's why your doctor needs 3 separate readings, and or you need 3 separate readings to diagnose hypertension. Now, hypertension is such a problem because you can see that it causes turbulent blood flow through the vessels, which is not very efficient and can lead to chronic changes of the blood vessel, like becoming very stiff. It can also cause lots of risks of other disease processes like strokes, vision loss, heart failure, heart attack, sexual dysfunction, and kidney disease. And it's at least the top 5 cause of all of these terrible problems. So hypertension is a really big deal. It's really important that you understand it. To explain it, we don't have a way to evaluate, but I wanted to talk about how hypertension causes stroke. So if you have high blood pressure all the time, consistently, for months or years, you only have 2 ways in which you can go. First of all, because of all that big high blood pressure just constantly hitting, the vessels will start to thin and stretch. And eventually they balloon out and they cause an aneurysm. The most common place for this to happen is up here in your brain, as all of that pressure is just constantly hitting the blood vessels at the top of the brain. That's where the blood vessel starts stretching and the aneurysm forms. Now, over time, if that pressure continues, that stretched thin blood vessel wall, that's really easy to tear. And if that pressure keeps continuing, boy, that aneurysm can pop, and boom, you bleed in the brain and you have a hemorrhagic stroke. Now, the other process that can happen is instead of doing that, your body will try to fix itself. And what I mean by that is that blood pressure is just constantly hitting those brain vessels over and over and over for months and years, and it will increase the amount of muscle that you have inside your blood vessel. So the more muscular it becomes, the stiffer it becomes. And if it becomes stiffer, then it can't respond to dilation or constriction like it should. And because of that, it's smaller, more friable, and it's way easier to clog up. And so something is going to come down and clog up my blood vessel, and that's going to lead to an ischemic stroke, or what we typically think of as a stroke. So these are the two ways that hypertension causes stroke. Now, I also want to point out the red words on this slide, which is that hypertension causes stroke, but it takes a long time. We're talking about months or years of having really high blood pressures, not one blood pressure one time. A lot of people mistakenly talk about a stroke risk blood pressure. Like you have a blood pressure of 220 over 160, and you have that one time and they send you to the ER because they're so scared that this one blood pressure is going to cause a stroke. But unless you already have an aneurysm or you've had high blood pressure your whole life, unlikely that this one blood pressure is going to cause a stroke. That's probably my blood pressure when I finish running a 5K. So what you need to understand is that blood pressure in and of itself isn't the bad guy. It's the long-term picture that we're looking at here. Okay. And lastly, as I promised, I wanted to cover a couple of fundamentals about the cardiac diet, because I doubt a whole lot of people have been talking to you about this. When people talk about the cardiac diet or the DASH diet or the Mediterranean diet, there are a few fundamentals to know. All cardiac diets are intended to prevent fluid retention, right? The more blood volume we have, the harder the heart has to work, and the more cardiac output we have, and the harder it is on the kidney, and it's this terrible cycle. So the number one component of a cardiac diet is always going to be low salt. And we can talk about that when we get more into the kidneys and fluids and electrolytes, but you need to know that water follows salt. So if we have less salt, we have less water, period. I will leave that there. We also want to have high fiber. Fiber helps your body get all the micronutrients that we need, so that way the body can clear up a lot of those plaques or cholesterol that it has. And lastly, all diets for cardiac stuff always have low cholesterol. Now, I do add an asterisk here, and that is because of the ketogenic diet. A lot of cardiologists are starting to ask themselves, why are the folks on the ketogenic diet not having an increased risk of heart attack? And this is because we've started realizing that what we understand about cholesterol could be wrong. And maybe cholesterol isn't as much of a risk factor as we thought. And I'm not going to go a whole lot into that, but I do want you to know that if you want to be on the up and up and really the cutting edge of medicine, look up Dr. Nadir Ali. He is a cardiologist who is in Houston, who has done tons of talks about how cholesterol may not be as bad as we were all thinking before. He's a really good speaker for a cardiologist, and I think you should check it out if you want to. Finally, some aspect of the cardiac diet that you should know about is a nutrition supplement called CoQ10. CoQ10 is actually an enzyme, I should say. It's found in a lot of different kinds of foods. And what's found is that most people who have heart attacks when they're studied are very low on CoQ10. And because they're low, if you supplement with CoQ10, it has tons of effects. including increasing your recovery, decreasing your inflammation, decreasing your cholesterol, and helping you overall to get better. So it's not something that you could go home in your 20s and take CoQ10 and prevent a heart attack. But it does mean that for some reason in our American diets, CoQ10 is missing. And the older we get, the more susceptible we become to CoQ10 deficiencies. So if you have a patient who's not in the best heart health, CoQ10 can be a really good supplement to add, both as a supplement or in their diet. Notice things like fish, especially tuna and salmon, are really high in CoQ10. And there's things like avocados and broccolis and strawberries and all the other things that are in those pictures that can really make a difference. And that ends the intro to cardiology. I realize that was a lot. I realize that you may have some questions. Remember that I'm trying to give you the big picture to help you organize it all together. So if you have a whole lot of questions, or if that was particularly confusing, or if you just want to hang out with me and do a few cases, join me at the live Q&A on Zoom on December 7th. I will see you guys there, or at least some of you, I hope. Bye.